Hi everyone, it's Hunter Hicks. Today we're going to look at some cholesterol medications. So we know when we look at our cholesterol, we have our very low density lipoproteins, which are mostly triglycerides and some cholesterol. We then have HDL, which are again cholesterol, but the good thing about them is they take the cholesterol from the peripheries and bring it back to the liver. We then have our LDLs, which are going to be mostly cholesterol, and they're the ones that really the biggest ones we're trying to treat because they increase our risk for our atherosclerotic plaques. Now, how this works is they overall are going to deposit this cholesterol in the blood. And eventually, we have monocytes that become macrophages that eat these guys and become foam cells. Well, they'll eat them. And while this is going on, we're causing damage to the wall. We're causing inflammatory processes. We're making a lot of things happen. Well, they'll get larger and larger until they become kind of this fatty streak. This fatty streak then can either stay there, or what it tends to do is break open. And when it breaks open, it's going to expose the endothelium with under it. So when it does that, we know that platelets are going to come here and try and plug up the bleeding or the clot within there. So when they do that, we get this huge increased risk for clot formation or this lesion, right? So again, we have our LDLs that come in here. They just cause, in general, they cause damage to this, which causes an increased risk of inflammatory cytokines. They're going to give us the monocytes that become macrophages that eat them become foam cells, which is going to cause turbulent flow because, as you can see, turbulent flow here, which is just going to cause everyone to want to stick to them. But eventually what happens is they break open, causing bleeding or the endothelium to be exposed, which makes the platelets want to come here. Eventually we get a clot and we run the risk for a myocardial infarction. Now, in general, when we look at the cardiovascular disease risk assessment, we have really the assessment of how likely you are to get this cardiovascular disease over the next 10 years. So 20% or greater when we look at this risk score is going to put you in the class to being like, we need to treat you. So some things we'll look at is like age, total cholesterol, if you're a smoker, HDLs, your systolic blood pressure. So as you can see, like we want our LDLs to be less than 100. If they're above 160, that's high. We want our HDLs to be above 60, which is desirable. Triglycerides, we want less than 150. So LDLs, we want less than 100. HDLs, greater than 60. Triglycerides, less than 150. Fasting glucose, we want less than 100. Blood pressure above 130 over 80 or stage 1 hypertension is a big deal. And then waist circumference greater than 40 for men, greater than 35 for women. All of these things, plus these things up here, give them certain points. Those points then convert to percentages. If it's over 20%, we know we want to treat them. So in general, one of the most common cholesterol medications are our HMG-CoA reductase inhibitors we call statins. So HMG CoA reductase is the rate-limiting enzyme that eventually gives us cholesterol, right? Gives us LDL. So when we block that, the liver is going to actually make more HMG-CoA reductase at first, but eventually what it does is just make more receptors for LDLs, and it actually just removes more and more LDLs from the body. There's more receptors on the liver and removes more LDL. So it has a lot of beneficial actions, our statins, like atorvastatin and simvastatin, or sometimes heard as Crestor. It's going to decrease LDLs, increase HDLs, possibly lower triglyceride, and also create plaque stability. Well, what does that mean? Well, we know what the plaque we just looked at. Usually what the plaque is a lipid core, those LDLs, with a fibrous cap. Well, the more that core is full of lipids and the bigger that core, the more likely we say it's immature or it is less stable. Therefore, it wants to break open. When it breaks open, more platelets are going to come and possibly cause a clot. So this helps keep it more stable. Some of the uses are going to be high cholesterol, prevention for CV risks, post-MI, diabetes. Some patients even take Crestor for normal LDLs to help prevent CV risks and stuff like that, even if your LDLs are not high. Some of the adverse reactions, myopathy can be seen, so that's weakness, aches and pains they might get in their muscle. Rhabdo, though very rare, can happen. And then hepatotoxicity, liver injury can happen here as well. But again, we can use it in non-alcoholic fatty liver disease. But if they have any other kind of liver disease, we want to be very careful giving these medications. In general, they're not safe in pregnancy. Now, niacin we used to see very commonly used a while ago. It's vitamin B. And niacin was that medication or whatever that someone would take and they'd get really hot, really red. Well, they found that the outcomes weren't the best versus these statins here. And it actually can be harmful, therefore we don't use them as much. So some other medications that we can look at is bile acid sequestrates like cholestyramine. So cholestyramine, what happens here is bile acid is usually secreted into the intestine and then it's actually reabsorbed and reused. What cholestyramine or bile acid sequestrants do is they prevent this. So by preventing this, then the bile just goes out the body. Well, in order to make bile, we need to use cholesterol. So obviously, we're not reusing our bile anymore. So what does the liver do? He says, I'm going to create more bile acid because I don't know where it went. So I'm going to do that by using more and more cholesterol to make my bile acid. Therefore, we get more LDL receptors and we get less LDL in the body. The only really adverse reactions of these guys is the bile is not reabsorbed, and these medications aren't reabsorbed either, so it can cause a degree of constipation, but because it's not reabsorbed, systemic effects are pretty rare. Last but not least, fibric acid derivatives like gemfibrozil, it can lower triglycerides and very low density lipoproteins. Some of the adverse reactions are gallstones are going to be high risk with our fibric acid derivatives. And again, we can see myopathy and liver injury just like we saw with our statins. Again, that was quick, down, and dirty. If you have any questions, give me a comment. I'll see you next time.